a lump on the top of the shoulder for 1.5 years, getting larger, tender to touch. What that usually means is there's a lipoma, there's lipomatosis, the patient's been eating a lot, but usually there's nothing there. And in this case, there's not much there, just a lot of fat. Now, there are conditions where you can get painful fatty change around the shoulders. One condition is known as Madelung's disease, the other is known as Derkum's disease. But we stumbled on an interesting finding. We talked about the assessment of muscle size and how it influences what you're going to do for a patient. For instance, in this case, we have grade 3 out of 3 fatty infiltration. We have grade 2 to 3 muscle size loss of the supraspinatus. If this tendon is diseased, fixing it is going to be fraught with challenge. Is it diseased? Let's have a look. That's not why we were doing the study. We were doing it for her lump. And when I look at a study, I like to look at it in the beginning from about 10,000 feet. How's the humeral head sit in the cup? What's the shape? What's the conformity? What do the health of the tissues look like? What's the patient's body type? What's the patient's body habitus? Then the next thing I do is I decide on the patient's age, what their activity is. I do this all before I really drill into the case, and I do it quickly. Then I figure out what kind of scanner it is, high field, low field, which sequences work for the shoulder or body part for this scanner. And I know that very quickly from experience. And the next thing I do is I decide what's the quality of the sequences that I have. For instance, if you look at these two images, the hyperintensity is pretty conspicuous, but the fat suppression, not all that great. Right? Look at the fat. It's kind of gray. The muscles are kind of gray. So overall, I've decided that this is a mediocre to slightly better than average water-weighted image. And I take that into account in deciding on how aggressive I'm going to be or how hard I'm going to look at an object. In other words, my sensitivity may be heightened or lowered based on the quality of the image. That's a very sort of fine-tuning approach that I want to share with you as you look at your own cases. Now, that's less of an issue on T1. Almost all T1s are the same unless different field strengths. By the way, T1, better at low field. T1 contrast is better at low field. But in Australia, that's a no-no, because low field is a bad thing. How's my T2 look? Quite good. It's not fat suppressed, but quite good. All right, let's go back to my water-weighted images. We've got some high signal intensity areas, so that draws us right to the area of interest. We were alarmed by the marked atrophy of the supraspinatus, so something is going on with the supraspinatus. What could give you massive atrophy like that? Well, certainly a brachial neuritis could do it, Parsonage-Turner syndrome, but also just disuse. So let's look at our supraspinatus. It's ill-defined. It's gray. But the image is kind of gray, isn't it? So you have to drill a little harder into a case like this, because you don't have the contrast resolution that you really would love to have. Nice and black and nice and white. But that is a sick rotator cuff. So how would I start describing it? Tendon, fiber, failure. Where are my intrasubstance fibrils? Where is this? I want to see parallel fibers in my tendon. I don't. So that's a nice way of dismissing what is a very sick tendon. Intrasubstance, confluent tendinopathy, and/or footprint tendon fiber failure. We still have to figure out what's going on here. We're not there yet, but do we have anything focal that could explain a connection between that lesion and the joint space? Maybe. How about right there? It's a definite maybe. It's still a definite maybe, but it's getting more probable. Well, let's look at the sagittal. So we've got to really drill into this case. Let's go out to the side. And I'm going to window and level it because I want a little crispier contrast because they didn't give it to me. I'm giving it to myself. There she blows right there. That's not all. This is the supraspinatus. We're in the sagittal projection. Supraspinatus, infraspinatus, what's in between? The fibroelastic membranous connection between the two, known as the posterior rotator interval. Where do these cysts often come from? The posterior rotator interval. So we have two options. It could have come from here, or it could have come from this tear. So let's scroll. I would admit it's hard to decide if that lesion is coming from here or coming from here. The answer is it's coming from here because it was operated on. Now follow it. It balloons into this large mass, which dissects along the central tendon of a degenerated supraspinatus muscle. This is known as a sentinel cystic tear. They usually arise from diastatic tears of the membranous interface between the supraspinatus and infraspinatus. And yes, immediately adjacent to it is another tear, a vertical, longitudinal, 3/4 thickness pinhole tear immediately in front of it. That will get a description. I'll describe the size of the cyst and the peritendinitis and the tendon fiber failure. We have another high signal area to address, separate and distinct from the cuff. It's in the inferior labrum. It's an upside down slap lesion. Instead of superior, it's inferior. These are not associated with dislocations, the ones with inferior cysts. The cysts usually dissect into the axillary space, and we refer to these as upside down slaps or slap 11s or slap 12s. We won't go into the distinction right now. So how would the conclusion read in a case like this? Well, we do have a pointed acromion and a thick coracoacromial ligament, so my conclusion would read outlet-related impingement with acromial remodeling and thick CAL contributing to broad, confluent, footprint, tendon fiber failure, and confluent tendinopathy, period. Associated small pinhole, 3/4 thickness, posterior supraspinatus microtear, period. Rotator interval tear with sentinel cyst formation, producing a mass, and degeneration and atrophy with 3+ fatty infiltration of the supraspinatus, mass X by X by X centimeters. Number 2, perhaps incidentally noted, inferior labral tear with paralabral cyst formation. That's a neat little case. By the way, they did find a lipoma, but I don't think that's a good use of our time. The patient fell on Thursday. The problem is I don't know what day it is today. Thank you. I think that means that the MRI is pretty acute relative to the actual event. 69 years of age. Start out axial. It's a mess. I mean, what do you do in a case like this where everything looks horrible? Well, I would start with our system. You know, I'd start from the top down, work your way down from the axial. Where's the rotator cuff linear fibers? Right, there should be some fibers going through here. They're gone. So we've got a rotator cuff problem. Okay, let's take it cuff by cuff. Do I see supraspinatus? Not really. Do I see infraspinatus? Not really. Do I see subscapularis? Yes, but not attached. Do I see the biceps, structure by structure? Yes, but then it disappears. How about the teres? I'm not going to bother. It never tears. How about the coracohumeral ligament? It's rolled up in a little ball. And besides, when you have a massive supraspinatus tear, the coracohumeral ligament is always torn. So we've already established that we have at least 2 or 3 or 4 components of the rotator cuff that are gone. What about the conformity and configuration of the cup and labrum? Not bad considering the severity of injury. How about the labra? Chronic, mixed signal intensity anteriorly, no signs of a dislocation, no signs of a Hill-Sachs, chronic degenerative tears of a middle-aged to elderly woman. Common. Don't touch it. Joint space? Chondromalacia. That's called living. How about a fracture? She fell. Nope, no fractures. How about rupture of the capsule? Yep. That's how all that fluid got out there. Let's keep looking, shall we? What's all this? Muscular tissue? Could she have a muscular tear? So with the axial projection, we've already figured out she has a massive rotator cuff injury, possibly a muscular tear, and she didn't dislocate. That's pretty good, right? We haven't looked at most of the study yet. Let's do it. I'm going to put up the coronals because there are 3 of them, and I like lots of things. When I have more, I go for it. So more information, faster diagnosis, and I'll finish it off with my sagittal. So our greatest fears are confirmed. She has a massive rotator cuff tear. It's not a secret. I'm showing the case for its systematic evaluation. We have a medial lateral dimension of the tear that is, 5.5 centimeters. Add a centimeter because it's curved. So 6.5 centimeters of retraction. Or said another way, retract it to the AC joint. The infraspinatus, same thing. Subscapularis, same thing. Upper fibers, middle fibers, lower fibers, they're all off. There's a big hole in the middle of the subscapularis. You were asking about subscap tears earlier. This one is ruptured. Biceps, we already established that is ruptured. Decentering, absolutely. Arthritis, absolutely. AC joint separation or fracture? No. But she does have a large gap there because somebody went in and cut it out. She had a prior Mumford procedure. Okay. That's old news. What's new news? There's more new news. I'm going to scroll and ask for your new news assessment. What do you think of her axillary pouch? It's pretty floppy, isn't it? So now we have to define the anatomy. Is it attached to the humerus? Well, when you glance at it quickly, you might say no. But when you really concentrate on the anatomy, you say, yes, it's attached. And then it loops back over on itself. But it shouldn't do that, should it? It's supposed to go from the glenoid to the humeral neck, not from the humerus to the humeral neck. It's come off and scarred to the upper portion of the humeral neck. So not only does she have rotator cuff pathology in every corner of Australia, including Broome, she's got a rupture of the IGHL from the inferior glenoid known as a gaggle, a glenoid avulsion of the glenohumeral ligament. What's this bright area up here? Blood. Her muscularity? Poor. Her muscle size? Poor. She is not a good candidate for repair. She has multi-tendon disease. She has multi-directional instability. She has arthritis. She has no muscles. She's a candidate for a shoulder replacement. Shall we do another?
164, 164.
This is a 47-year-old female with pain for a month. She fell out of a chair and now complains of decreased range of motion. So this is more of a case of how I do it, how I say it. The findings are obvious. It's how you describe them that's the challenge. So let's scroll axially. I know that I have 2 millimeter gradient echo images that are strong for tendons, that are strong for articular spaces, not very good for bone, and I've got decent resolution and good water emphasis. So I'm going to see a lot of water signal intensity on this image. So immediately I am drawn to the area of abnormality. I'm like you. I'm working. I've got to keep my job. I've got to be moving and grooving and not spending an hour reading this case and getting the answer right. Swollen, diffusely. Where are the internal fibrils of the tendon? So whatever it is, it's confluent. That's a good word, right? And then you could throw in another adjective, like mild, moderate, or marked. How about moderate to marked confluent? And then we have to say confluent what? Tendinopathy, hypertrophic tendinopathy, hypertrophic tendinopathy with intrasubstance tendon fibril failure. All of those would work. They work for me, so I hope they work for you. Let's keep going, shall we? There's a little bit more going on. There is a pseudocyst of the lateral wall of the bicipital groove, and usually those pseudocysts arise because there is a problem with the biceps pulley mechanism. Sometimes it's a result of a tug phenomenon from the transverse ligament and the subscapularis fibers. Occasionally it's from internal rotation and abutment against the coracoid. But that will not be the focus of this case. And admittedly, the biceps is tendinopathic and diseased. But let's focus on the cuff. We're going to pull down our two coronals, morphologic, anatomic on the left, water weighted in the middle, and the sagittal on the far right. My favorite combination is coronal PD spur, heavily water weighted, also known as PD special, PD fat sat. Sometimes it's called chem sat. And a T2 fat sat sagittally. So the T is longer. Why is the T2 helpful? The T2, when you have excessive swelling, massive swelling, it'll bring down the signal intensity of tissues that are chronically diseased. But the tissues that are acutely hot will remain bright. So it's a refiner. It's kind of like wax on, wax off. On the other hand, the PD is more sensitive. So when you have an acute scenario with massive swelling, the T2 can be a very complementary sequence. Let's take the reverse of that. What about a chronic scenario? We've got a chronic tear, a chronic ligamentous tear, a chronic tendinous tear. What's in the tendon? Blood. What's the signal of chronic blood on a T2? Black. Signal of hemosiderin on a T2? Black. Signal of fibrous tissue on a T2? Black. What's the signal of a tendon? Black. What's the signal of a ligament? Black. So what happens in a T2 in a chronic case? It looks like the ligament or tendon is still there because everything is black. So the T2 is limited in chronic scenarios. It's best suited for hot, acute, swollen scenarios. So we have a swollen scenario, and now we have to finish out the description. On the T1, the cuff is diffusely gray, swollen. Do we have an area where the cuff is morphologically separated from its attachment or a full thickness tear? And the answer is, we do, right there. Let's blow it up. There's our sick, tendinopathic, tendon fiber failure, hypertrophic cuff. But right there, defect. That's known as an avulsion tear or a footprint avulsion tear. Now, avulsion doesn't mean bone. It means the tendon is avulsed from the bone. Can we see it sagittally? You bet we can. That cap of dark signal, which looks a little bit like Bart Simpson with Bart Simpson's hair. There's the hair. Maybe Bart Simpson's hair is a little roughed up over here. And then there's no hair right here. Where is Bart Simpson's hair? Over there. It's a hole. It's missing. What's in there? Inflammatory tissue. So there is a small, chronic, or subacute, full thickness tear with interstitial dissection into the midfibers of the supraspinatus, with a slightly swollen infraspinatus, with peritendinitis, a remodeled humeral head, pitting, and hypertrophic tendinopathy with tendon fiber failure. Let's look at the subacromial arch. It's actually not too bad. There's no big spurs. Let's look at it sagittally. It's a little hypertrophic. The ligament, the coracoacromial ligament, is a little bit thickened. So how would this conclusion read? It would read as follows. Supraspinatus confluent tendinopathy and areas of anterolateral tendon fiber failure with multiple foci of interstitial microtear and a small avulsion tear at the anterior foot plate or footprint. Number one. Number two, innumerable pseudocysts in the anterior humeral head, suggestive of abutment or impingement syndrome. Number three, biceps tendinopathy and or chronic tear in the extraarticular space. Let's do another one, shall we? It's kind of a how I do it case. This is a 55-year-old male complaining of shoulder pain. He had a lifting injury 7 years ago. It sure took him a while to get in, huh? He must be from Canada. So we'll start out with the axial. These are 4-millimeter cuts. This is a gradient echo with fat suppression, so I know it's an articular sensitive sequence. It's water sensitive, and the quality of the fat suppression is high. So I've got very good tissue contrast resolution. My in-plane resolution, very good, small field of view. My through-plane resolution, modest, 4 millimeters. So I might get some volume averaging. So I'm thinking all of those things as I look at this case. And I'm thinking, what happened? How old is he? It's a man. How muscular is he? How centered is he? What is the relationship of the cup and the head? All those things are going through my mind as I scroll in 5 to 10 seconds. We have quite a few hot spots. And that's really a nice way for you novices to look at a case like this. Just look at it like a bone scan. Where are the bright areas? That's easy. Then you try and figure out what the bright areas mean. So the bright areas are anterolateral, and at least one of them appears to dissect into cuff tissue. Our labra looked pretty good. Nice and pointed as we come down. Well defined. The humeral head is centered. Let's look at something more vertically oriented. Our coronals. We've got 3 of them. A PD, a T1, a T2. Now this structure right here, which is often confused with a spur, that structure is the coracoacromial ligament. It's thick. That is not a spur. We've got a humeral head. And the humeral head has a cuff coming on top of it. I think I'll draw the cuff in another color. and we can see parallel fibers in our rotator cuff, and it has a footprint of insertion right there. If I tear this locus right here, oh, that's a bad color. Let's go black. If I tear right here, you can't see it. The surgeon can't get to it this way, surgeon can't get to it that way, it's concealed. It's a concealed interstitial delamination of the footprint. What if I tore over here, right there, medial to the footprint, right along the humeral head? I'd call that an articular surface tear. Might go up into the tendon halfway, 3/4 of the way, all the way, or through as a pinhole. And your job is to decide whether it does that. 1/4 thickness, half thickness, 3/4 thickness, all the way through. If it just involves the articular side, that's called a supraspinatus tendon articular sided tear, Stoss lesion. Let's keep going, shall we? Let's put our cuff back now. Let's put Humpty Dumpty back together again. What if I had an articular surface tear, and my tear, instead of going north by northwest towards Broome and Perth, it decides to go towards Queensland? It goes this way, or maybe towards Brisbane. But it doesn't go out into the ocean. It stays on land. Now, it is an articular surface lesion with interstitial extension, a partial articular sided tear with interstitial extension called a paint lesion. So now we've got a CID, concealed interstitial delamination, which is not exposed, an articular surface lesion called a Stoss lesion, which you can see from the inside out, but not from the outside in. And we have an articular surface lesion with interstitial extension, which you can see from the inside out, but not from the outside in, called a paint lesion. Oh, there's more. There's a lot more. What would happen if we sheared off the deep fibers of the rotator cuff? These fibers. If all these fibers were torn and they retracted back to here, but the outer shell was left intact, can that happen? In other words, can the rotator cuff do this? Slide out the deep fibers? You bet it can. That is called a pasta lesion, a partial articular sided supraspinatus tendon avulsion, usually without bone. Could it happen the other way, where the outer layer comes off, but the inner layer stays on? An upside down or reverse pasta lesion? Could. In fact, it did. The deep fibers are still on, but the outer fibers are off. It's a reverse pasta tear. The T2-weighted image shows it probably even better. Deep fibers present, the outer footprint fibers torn right there. Ooh, that's pretty. Deep fibers present, outer fibers not. Let's look at the sagittal. Very hard to see the deep fibers, but they're present right there. Look at the little step off. Superficial outer fibers present, superficial outer fibers absent. Defect from here to here. So the anteroposterior length of the tear, 2.4 centimeters. The medial lateral dimension of this upside down reverse pasta lesion is 1.5 centimeters. Bursitis, pronounced. Subacromial impingement, pronounced. Number 1, the star witness in the conclusion is supraspinatus, high-grade, reverse pasta, and then in parentheses, partial articular-sided supraspinatus tendon avulsion tear, greater than 50% of the depth of the cuff, X by X centimeters in transverse dimension or retraction and AP dimension with subacromial impingement produced by coracoacromial ligament hypertrophy. Pronounced bursitis, end. Shall we do another? That's a cool one. By the way, there was a little arthritis there and a few other minor findings. 51 years old, shoulder pain for 2 months, accompanied by limited range of motion and arm weakness. It's a man. Jump right to my axials. Water-weighted field echo, fast field echo. FFE means something to me. It means it's a Phillips machine. And I know Phillips machines like I know my dog. I know Siemens machines like I know my son's dog. And they don't behave the same way. So if you're reading on different equipment, you've got to learn how to read off that equipment. Fortunately, most of you are reading off of only one type of equipment. But it absolutely influences how I read the case and which sequences I use. This time, I don't have a lot of fat suppression, but I do have a gradient echo. So I know it's articular sensitive, it's got pretty good water sensitivity, it'll be good for tendons, but it isn't fat suppressed. So let's start up high. It is said that the rotator interval is a triangular space. You hardly ever get to see the triangle, but today, you do. There's your triangle. And then we've got some linear fibers. You've already seen cases where the fibers were gone, distorted, infiltrated, destroyed, failed. There's some fibers present here. Let's go down. We're high. Let's go low. Now, as we get a little lower anterolaterally, the rotator cuff fibers demonstrate a defect, don't they? And perhaps another defect, although there's a little pulsation nearby. The defect's still present. Let's keep going, shall we? A little bursitis, intact biceps, subscap, intact, teres, intact, down low, infraspinatus, intact, centered properly, labra, normal, muscle size, reasonable. We have another axial. Let's skip it. Let's go right to the coronal. Let's go right to the coronals, because there's lots of them. We Americans, we like lots of things, big things. Like Texas. So you've had challenging cases with areas of ill-defined signal and weird tears like reverse pasta lesions and CIDs and articular-sided tears. Here's just a straightforward one with a big, fat, thick acromion and a big, thick CAL pressing on the subacromial arch, an impinger. But the impingement is a lot worse when the arm is up like this. There's even impingement when his arm is lying down at the side. So here I would describe subacromial, morphologic, bony, and ligamentous impingement associated with diffuse tendinopathy with interstitial extension and a full-thickness avulsion footprint tear. How big is the tear? In the conclusion, I'm given the size, so I'm going to measure it. The medial lateral dimension is 7 millimeters. How about you measure the AP dimension? There it is. AP dimension, 9 millimeters. So 7 by 9 millimeter rotator cuff footprint avulsion tear accompanied by bony and ligamentous subacromial impingement. That is going to be number 1 in your conclusion. What am I going to do with the acromioclavicular joint? It's a man. He's middle-aged. He didn't describe pain on top. It's not very impressive on the T2 weighted image. Everybody's AC joint is bright on high-quality fat suppression imaging. It's arthritic. It's going in the body of the report. Moderate, hypertrophic, osteoarthritis of the AC joint without active inflammation or with scant inflammation. It's not going in the conclusion. I don't want to draw anybody's attention to it. Anybody have any other comments on this case? Muscularity, slightly decreased for age. I like to see the muscle fill out this fatty space, but he is a definite surgical candidate. So while you're looking at this case, got a great view of the foot plate or footprint of the infraspinatus, that firm attachment right there. Tears in this location are going to be concealed. The area immediately medial to that is devoid of cartilage. Here's some cartilage. This area right here is known as the bare area. You can get tears right over the bare area or along the undersurface of the cuff, and then this would be articular-sided. We have innumerable posterior-superior, lateral pits and areas of pseudocyst formation consistent with somebody who's experienced friction-type impingement. Common. You used to hear this is a normal phenomenon because everybody has them. No, it's not normal. Might not be symptomatic, but it's not normal. While you're looking, I'll go back to my standard axial search. They've given me a proton density, relatively low in-plane resolution image. The field of view wasn't very small. Through plane resolution, 4 millimeters, skip 1, mediocre. So it's a mediocre axial. Fat suppression, moderate to good, but not fantastic. So extensive bursitis, focusing in axially on the cuff. Some interstitial signal within cuff tissue. It's time to go long axis. Now, this is another case where we have to get into the name game. Now, in naming these tears, one of the most important things that you must do is describe whether the clinician has access to the tear. And if so, is the access from the inside or the outside? So it's more important for you to decide if it's concealed, non-concealed, bursal, or articular than it is if it's full thickness. Those issues matter more. So clearly, it is medial to the footplate or footprint. Some of you are probably deciding or struggling with whether it is full thickness or not full thickness. It has been said that excessive bursitis is a sign of a full thickness tear. This is unreliable. So what would I do with a case like this? It's deep, it's penetrating, it's fairly broad. I'm going to describe it as medial to the footprint, in the cable portion of the cuff, a full or near full thickness, penetrating tear involving no less than 80 to 90% of the cuff depth, X by X centimeters, period. Now, the next question I'll get asked is, which side is the tear more likely to be visible from? So number 2, tear more likely conspicuous from the articular side. In this case, it's so deep it probably does not matter. They'll probe it either way. Number 3, subacromial impingement with coracoacromial ligament hypertrophy. Number 4, pronounced bursitis. So this is kind of a strange, more medially positioned tear. It's a deep tear, and it's one that you sit there and struggle over whether it perforates the outer fibers or not. In the end, it doesn't matter. In the end, what matters is it almost perforates. So a get-out-of-jail-free card way of describing it is deep, penetrating, full or near full thickness tear. Give the dimensions, give the location, you're done. And make sure you tell them whether it's concealed or non-concealed. So in this case, they might have to perforate a few fibers on the bursal side if they come from the outside. And you can tell them that, and that's fine. Do I think there might be adhesive capsulitis? Yeah, there probably is some type of capsulitis. Generally, I like not to diagnose adhesive capsulitis in patients that have florid rotator cuff tears. The two usually don't go hand in hand because people are usually moving their arm around. But yes, you're right. There is capsulitis. It probably is fibroinflammatory. How would we describe one like this? Well, it's a woman. So I would probably say something like fibroinflammatory thickening of the axillary capsule consistent with dry capsulitis. And I probably wouldn't introduce the adhesive word in there. But I think you're right. She does have it. But as a general rule of thumb, they don't go together. Especially when the cuff opens to the outside, the fibroinflammatory reaction can decompress. This is probably one of the few examples where the two are coexisting. So I am given an axial additive gradient echo, high signal to noise, contrast resolution moderate, articular sensitive, calcium sensitive, blood sensitive, siderotic sensitive. Water, moderately sensitive. Through plane resolution, good, 2 millimeters. In plane resolution, good, field of view reasonable. Fat suppression, not so much. Let's scroll. Top down, extra objects of hypointensity. Down low, nothing. Rotator cuff, present. Subscapularis, present. Biceps, present. Centering, normal. Labra, normal. Capsule, normal. Chondral interface, close to normal. Let's look at the long axis. Patient moved a little bit. That's rather strange looking, isn't it? That dark signal intensity we were looking at is a band. And around that band is some swelling. Non-focal. It's ill-defined. So if you were to call that a tear, you'd be making a mistake. It's not focal enough. There is an area of abutment of the acromion and ligament in contact, even with the arm at the side, with this area that is inflamed and irritated and has produced this, which is what? Calcific tendinitis, also known as HAD, hydroxyapatite deposition disease. So this is a weird manifestation of HAD. For HAD is usually on the outside, where the superficial surface of the cuff is irritated or rubbed, not usually within the cuff itself. It's usually a peritendinitis. So this is one of the few examples that you'll see of intratendinous HAD as a manifestation of outlet-related impingement syndrome. See, what else do we have in this case? We had some AC joint disease, but everybody's got that. I put up my first axial. It came off of a Siemens machine. Came off of a Siemens 1.5 short bore. I happen to know that machine because of its shorter bore has lower contrast resolution than standard 1.5 Tesla machines. So I've already started to adjust my internal sensitivity. Once again, I'm looking at a gradient. This is a standard 2D gradient, not fat suppressed, water sensitive, in plane FOV or resolution, good. Through plane resolution, 4 millimeters, fair. We've got a large fluid collection in the subacromial subdeltoid space. What does it mean? We've got a gorgeous view of the fibers of the supra and infraspinatus. There they are. They're normal. We can see our biceps labral anchor. It's normal. Our subscapularis is normal. Our labra are normal. I don't think we can ascribe cuff pathology as the cause of our collection. Let's go long axis. T1 on the left, T2 in the middle, T2 fat suppression on the right. So two T2s, not a PD, T2. So flatten out your T2. I'm going to put up my sagittal. It's another T2, fat suppression, to look at the internal character of this bizarre collection. While I'm scrolling around, I've noticed that the patient isn't using her arm much. She's got generalized muscular atrophy. She's got fatty infiltration. She must be in a fair amount of pain. She has a completely normal humeral head position. She is not decentered. She does not have cuff pathology or disease. So what's our differential? What might we consider? A bursitis, a bursosynovitis, CPPD, synovial metaplasia arising in a bursa. and unlikely something like amyloid, which can present with a shoulder pad sign and a massively distended set of subdeltoid bursa. So let's go to the next case, 177. She's back. Wow. What do you like now? It is impressive that her joint is dry, right? So some of you might have been thinking rheumatoid. It's a woman, it's a middle-aged woman. It's pretty hard to get this amount of swelling without any joint pathology in either the AC joint or the glenohumeral joint. So I think you can set rheumatoid aside for that reason. You can also set it aside because the synovial proliferation of rheumatoid is more delicate. It's not as big as these structures, so-called rice bodies. So we have to move in another direction. What might that direction be? How about synovial metaplasia, like primary synovial chondromatosis? Is that the right shape for a chondromata? Yes. Is that the right signal for a chondromata? For multiple chondromata? Yes. That would be a high choice. What about CPPD? CPPD in itself wouldn't explain these objects that have grown in size. So there could be complicating CPPD. CPPD could be the inciting factor that led to a metaplastic response. So it could be secondary synovial chondromatosis due to CPPD. That's a possibility. What about amyloid? Amyloid, large confluent masses. Patients are usually sick. They usually have renal disease. So not so good. How about gout? It's a woman. Too many objects. Too repetitive and identical to be gout. Gout more random. So gout is out. So we are left with some form of synovial metaplasia, either primary or secondary. It's important to make the distinction because primary synovial metaplasia can occasionally dedifferentiate to chondrosarcoma. Secondary irritant-induced synovial metaplasia never does. Now, sometimes you just can't tell. One of your colleagues suggested a brilliant diagnosis, and that is underlying CPPD. The patient had an underlying endocrine abnormality unrecognized, did have CPPD. This is secondary synovial chondromatosis from occult CPPD. Great case. She was hypothyroid, which you might have suspected from her body habitus. Pain on top. The pain radiates down the arm. The patient has clicking and decreased range of motion. Pain also radiates into the left neck. A motion mismapped axial gradient echo off of a Siemens machine. 4 millimeters slice thickness, large patient. Swollen shoulder, slightly to center due to internal rotation. Let's pull up the long axis. The head is slightly decentered superiorly, and the shoulder is diffusely inflamed. All right, let's assess the cuff. Anteriorly, it looks fine. Let's follow it back. What are we going to call that? We're going to call that a concealed interstitial delamination tear. In fact, we're going to call it a CID/micro tear. Is it symptomatic? I think not. Is it surgical? I think not. So I might say, incidentally noted, is a 2 by 2 millimeter concealed interstitial delamination micro tear of the infraspinatus. Do we think that tear is causing all this? I think not. So it's important for you to categorize and place the right context and adjectives around these lesions. Otherwise, you're going to cause unnecessary intervention. Let's keep going, shall we? There's a little pitting postero-superolaterally. She's an impinger. But quite severe symptoms for such a small rotator cuff lesion. By the way, when these little tiny tears perforate the bone, they're called rim rents. So that's another adjective. This one did not. So what is causing her pain and decreased range of motion? You don't want to sit there and list AC joint arthropathy, rotator cuff partial thickness tear, effusion. You want to come up with a diagnosis. When I train a fellow, a resident, a colleague, the first thing I ask them is, tell me what's wrong. Don't tell me the findings. You've looked at the case, give me the answer, then work backwards. I want to know what you think is wrong with the patient. What's wrong with this patient? She has biceps, peritendinitis, and, again, metaplastic bodies. Look at them. Multiple chondral metaplastic bodies from irritation. And what was her irritation from? Underlying CPPD, another one. So it wasn't the rotator cuff pathology, it was the CPPD and the secondary synovial metaplasia. That's number one in the conclusion. What do I do with the rotator cuff tear? Didn't even put it in the conclusion. What do I do with the AC joint? Moderate AC joint arthropathy in the body. What do I do with the slight irregularity and fibrillation of the superior labrum? In the body. Next. I have a not very attractive axial gradient echo. It came off of a GE scanner. It's a 3 millimeter cut. The patient is large. The field of view is modest. There are multiple hypointensities. Again, multiple hypointensities around the rotator cuff. This time, they're not gray. They're black. The humeral head is centered. The labra are normal. There's very little swelling in the region of the rotator cuff. The coracoid arch is normal. Let's go long axis. Now, this is one of those times when the AC joint is relevant. It's massively swollen. It's got bizarre signal intensity inside it. It's compressing the muscular tissues underneath, so the medial arch is narrowed. There's medial arch stenosis. Some people say you shouldn't use the term impingement, it's a clinical word. But if you've got narrowing and inflammation and pitting and rotator cuff fraying and labral fraying, all the pathologic signs at arthroscopy of impingement, I think it's fine to extrapolate impingement. So impingement is often referred to as a clinical syndrome, as opposed to stenosis, which is just simple narrowing. Now, in the medial arch, you will frequently get stenosis, but you will rarely get secondary failure of the tissues underneath. So stenosis without impingement is common here. Stenosis with impingement is common here. This patient has innumerable areas of dark signal intensity reminiscent of HAD, hydroxyapatite deposition disease. But in the joint too. Let's look at the sagittal. What's going on in the subscapularis? Whatever this process is, it's in the subscapularis with some additional hypointensities. No, we're not done yet. Look at the front of the joint. Look how swollen it is. So the patient has severe, constant, sharp pain over a year, and there's another piece of history I've withheld. She's in renal failure and on dialysis. This is what's known as mineralizing arthropathy of the shoulder with amyloid. So you finally got to see one. Without that history, it'd be a challenge. Now, what is actually chemically in here? This is a subset of HAD, hydroxyapatite deposition. Calcium, phosphorus, and amyloid tissue. The history was critical. All right, let's move on.